Good morning, everybody. Today is a very special day in Louisville because it's one of our endowed lectureships, and I'm going to read off of your brochure about Beverly Todd Towery. He was born in 1915 and thus was just the right age to be part of the dramatic advances in medicine during and after World War II. He loved the clinical aspect of his profession, whether he was at war helping or whether or not he was here teaching. And he really loved bedside teaching. He was at his best when he was doing either one. And for his background, he actually grew up in Kentucky, and he went to Western Kentucky State College, received a bachelor's degree in 1936. He graduated first from his class in Vanderbilt University School of Medicine, and then he interned at Vanderbilt Hospital and spent a year as a resident in pathology. In those times, you know, no matter what you ended up going into, oftentimes you trained in all of the basic sciences and pathology and lab medicine, et cetera. And so you'll find a lot of people really had an extended education before they decided on what they wanted to focus their career on. He ended up at the Mallory Institute in Boston, and then he was commissioned and went and fought in Italy and France, basically as a medic, and then came back as a major. Once he was a civilian again, he became a senior resident at Mass General Hospital, and he had the opportunity to work with Fuller Albright, which led to his lifelong preoccupation with endocrinology. Subsequently, he spent 2 years as a fellow at Thorndike Memorial Laboratory at Boston City Hospital, and he worked with Robert Williams. He returned to Vanderbilt as a Markle Scholar and the first chief of the newly established endocrine division. In July 1956, he came here and became professor and chairman of the Department of Medicine here. And with this arrival, students and house staff saw, a dramatic infusion of enthusiasm. And I believe then Dr. Little was exceeded him as the chief in Vanderbilt, and he was also a very famous person and a very good friend of Dr. Towery. So he also was a real human being. He had 3 children and a wife, and he was a cabinet maker. In 1970, he asked to be released, so he served as chair from 56 to 1970, and then wanted to be released and finish his career doing what he loved most, which was endocrinology. Unfortunately, he became ill a few years later and wasn't able to work as long as he wanted. But what happened after his death is his friends in the community and his followers got together and helped establish this lectureship. And so that's a way that we can memorialize him and thank him for all the work that he's done. And with that, I would like our guest speaker to be introduced by LaSalle. Come on up.
Good morning. I am delighted to be able to introduce one of our very important and lovely endocrinology colleagues, Dr. Richard Auchus. His lecture today is supported by an unrestricted medical education grant from Corcept Therapeutics and by the Beverly Towery Foundation, so we're delighted to be able to have him to speak with us. A little bit about Dr. Auchus. He not only has an MD, he also has a Ph.D, and he's a fellow of the American Association of Clinical Endocrinologists. He is currently at University of Michigan Medical School as an endowed professor there. A little bit about his background. He began his career at MIT, getting his undergraduate degree in chemistry, and then traveled to Washington University in St. Louis, where he obtained both his MD in medicine and his PhD in pharmacology. He then traveled to the University of Iowa, where he did residency. He did his fellowship at UT San Antonio in Texas, and then he spent some time in the military as well. And he did a year at UCSF as a research fellow as well. So he is well-traveled and well-educated. He is currently a professor of internal medicine and pharmacology at the University of Michigan, and he is the James A. Shayman and Andrea S. Kevrick Professor of Translational Medicine in the Department of Metabolism, Endocrinology, and Diabetes there as well. In addition, he's the Endocrinology Section Chief chief at the Veterans Administration, and so clearly is an incredible and well-stretched individual in his career. In addition to his clinical positions, he has received many awards, including the Air Force Commendation Medal. He received the Best Doctors in Dallas, Texas award not once but 3 times during his time down in Texas. He received the Pioneer Award from the CARES Foundation, which is an advocacy organization for individuals with adrenal hyperplasia, and he has had multiple visiting professorships around the country. He has done multiple invited lectures regionally, locally, nationally, and internationally, and he is both a reviewer and on the editorial board for multiple journals and grant organizations, both nationally and internationally. He mentors multiple graduate students, teaches multiple pharmacology courses, and has participated and does currently participate in multiple multi-centered trials and does perform ongoing research as well. He has 260 published or in-press articles, which is pretty amazing. And in addition to all of this, he is a hilarious, kind, thoughtful, and giving individual. So without further ado, I would love to introduce Dr. Auchus as he talks to us today about a contemporary approach to the diagnosis and management of Cushing syndrome.
Well, thank you, Liesl. I'm really delighted and honored to be here for this lecture that celebrates the memory of Dr. Towery. And I was reading about him, and how do you give a lecture about the man who was succeeded by Grant Little at as his job? I mean, that's a pretty tall order. But what I'm going to do today is I'm going to talk about what you might think is a rare disease. But as I go through the lecture, I want to emphasize for the people who aren't endocrinologists in the audience that, like everything we do in endocrinology, in Grant Little's time, we only saw, and in Dr. Towery's time, we only saw the severe disease. But now, most of the disease that we see is the mild disease. And there are important implications for diagnosing the mild disease and where your job as other people in internal medicine comes in, bringing those people to the endocrinologist. So these are my disclosures. So I want to start by saying that to begin with, Cushing syndrome is the most difficult diagnosis in all of medicine, because I cannot give you a single test or a single parameter that will give you 100% cutoff on. So if this lady walks into your clinic, you should be able to make the diagnosis. Does anybody know who this is? The lady on the left is Minnie G. That was Harvey Cushing's first patient that he described in the 1930s with the basophilic adenoma. And you can tell the muscle wasting, the central obesity, the osteoporosis, and this is a woman in her 30s. Okay, and this is a patient of mine that I took care of in San Antonio, and you can see the purple stretch marks. But today, the patients look like this. Okay, now if you saw this lady on the street, you wouldn't necessarily give them your card and say, I think you need a dexamethasone suppression test. But if you knew what she looked like a couple years ago, you would know that she has florid Cushing's because you can't see her clavicles. I call this the wedding gown test. I actually had her dress in her wedding gown to compare it with the old pictures. But in a thin person, you should be able to see these clavicle bones, and you don't here because of these supraclavicular fat pads that are obscuring it. But she hasn't gained 100 pounds. She's only gained about 5 pounds, and she doesn't have diabetes or hypertension. But she has a urinary free cortisol that's 6 times normal. So, and then the other point is that a lot of people come to us for obesity, but Cushing's is not just about obesity. And I think this is a good example. This is a 55-year-old woman that presented with a deep venous thrombosis, which is one of the problems, one of the complications that Cushing's patients get, weakness and hypertension. She had probably been sick for about 4 years. And she was pretty debilitated when she got to us. She had a very inherent tumor. Our neurosurgeon did the best he could to get it out. Her cortisol was improved but not normal. We knew she would recur. And we discharged her to a rehabilitation unit post-operatively. And so you see, this is the tumor, this this dark area on the side of the cella there that was adherent to the structures. So that all sounds like a good ending to the story, except she was found dead a week later of a pulmonary embolus in the rehab facilities. People die of Cushing's, and I've lost a number of people to Cushing's over the years. And so this is a serious disease, especially when it's undiagnosed for several years. So how do we start? So there are the discriminatory features on exam, which are proximal muscle weakness, osteoporosis, wide purple non-blanching striae. This is hemorrhage in new skin, and easy bruising. So these are all the catabolic actions of cortisol. These are the discriminatory and specific findings, but they're not the common findings, okay? Because people don't get these things until they've had it for a while. So it's also useful to think, before you get the purple stretch marks, people have dermal atrophy, skin thinning, because of the effects of cortisol on collagen deposition. And people who are over about 50 do not get purple striae, no matter how bad their Cushing's is. It's only young people that get the purple striae. The disproportionate supraclavicular fat pads, sleep disorder, and unexplained hyperglycemia. And so when people ask me about whether a patient has Cushing's or not, they're always giving me test results. And the biochemical data are important, but they don't substitute for the physical exam. And just like Dr. Towery would say, who was an expert in bedside teaching, what I emphasize to our trainees is the physical exam. How do you look for skin thinning? How do you look for disproportionate head and neck fat accumulation? These are the things that are important. So somebody gains 100 pounds and they don't have muscle weakness and they don't have skin thinning, they don't have Cushing's, okay? Or at least the Cushing's is not causing their 100-pound weight gain, all right? So you got to think about what should come together, and it's the catabolic features that are what should prompt you to test people for Cushing's. So how do we test? So there's 3 principles of testing and 3 strategies. So one is that the total cortisol production is elevated, and that is why we do a 24-hour urine-free cortisol, but it's not always elevated, and I'll explain this to you in detail in a second, and it varies with the assay. So all the papers that you read about from the NIH and so on, where they talked about what the cutoff values are, those were all done by immunoassay. We do not measure cortisol by immunoassay, urinary free cortisol by immunoassay anymore. We do it by mass spectrometry. And guess what? The normal range is different, and we haven't replicated those studies. So we actually do not know what a normal urinary free cortisol is with a mass spec assay. So it's sort of if it's high, it's useful, but if it's normal, it's not that useful. The second principle is that cortisol production is not suppressible, and this is where the dexamethasone suppression test comes in. We've sort of gotten away from that, but we've come back to dexamethasone suppression for ACTH-independent disease, for adrenal tumors. I'll explain that in a second. And then finally, the diurnal rhythm is blunted. And this is the first thing that happens in ACTH-dependent disease. And this is when we measure nocturnal cortisol levels. Now, the lab isn't open at 11 o'clock at night. So instead of doing serum cortisols, we now do saliva cortisols. This is readily available all across the country. And this is sort of the test of choice instead of the urinary free cortisol now. So let's look at each of these. So the urinary free cortisol. So cortisol is primarily metabolized before it's excreted. And a portion of it is cleared in the urine when it exceeds the binding capacity of plasma. So 90% of cortisol is bound to corticosteroid binding globulin and some to albumin. And so the free is sort of the non-CBG bound. So people with high urine volumes can have false positives. People with what we call the pseudo-Cushing state or non-neoplastic hypercortisolism, alcohol withdrawal, just simple obesity, stress, do not measure urinary free cortisols on people who are sick in the hospital. They will be elevated, and various psychiatric diseases. False negatives, under collection, early disease, and so on. And as I mentioned, most of the normal ranges you're going to see is with assays that we don't use anymore. So the daily cortisol production rate is about 6 to 8 milligrams per meter squared per day, so about 12 to 15 milligrams in the average person. And that cortisol is in equilibrium with corticosteroid binding globulin. Now, 10 milligrams a day is metabolized to these things, which used to be partially picked up by the immunoassay, okay, but are not picked up by a mass spectrometry assay, which is only going to measure this little bit, this cortisol, this 10 micrograms per day. So only 0.1% of cortisol is excreted in the urine as the urinary free cortisol. So when you make a little bit more cortisol, where is it going to go? It's going to go this way to the metabolites. So you have to make a lot more cortisol, and you have to exceed the binding capacity of plasma to come out in the urine. So in other words, if your cortisol is 12 micrograms per deciliter, 24 hours a day, you have Cushing's, but you will not have an elevated urinary free cortisol because you've not exceeded the binding capacity of plasma. Okay, so people have to have 20, 30, 40 all day long or most of the day to that. So normal urinary free cortisol does not exclude Cushing syndrome. Here's some data to support that statement. Here are control patients. This is people with pituitary Cushing's, ectopic, and adrenal. So you see only about half the people with pituitary Cushing's have an elevated urinary free cortisol, and about 3/4 of the people with adrenal Cushing's do not have an elevated urinary free cortisol. But those people who did have an elevated urinary free cortisol, sure, they had Cushing's. And I'm even going to show you 3 patients. I'm going to give you their urinary free cortisols, and you tell me who has Cushing's. Okay, so this is this woman in the black suit, the bodybuilder, and the fat lady. So it turns out the fat lady does not have Cushing's, and these 2 people do have Cushing's. Okay, so again, it's not a great discriminator. All right. But of course, if I gave you some history and background to what was going on with these other 2 patients, you would have suspected it. All right, so that's urinary free cortisol. What about the dexamethasone suppression test? We used to do, of course, Grant Little developed the 2-day, 4-day testing and so on. We don't do that anymore. We really restrict ourselves to 1 milligram and sometimes an 8 milligram overnight test. So you give 1 milligram at bedtime, which is 11 p.m., and then that should suppress the cortisol production in the morning. When I was a fellow, we used to say 5 micrograms per deciliter, but now the cutoff's been lowered to 1.8, which is 50 nanomolar, to be more sensitive. But of course, then you lose specificity as you drop the cutoff. Now you can measure a dexamethasone level, you can measure ACTH. I don't normally do that, but if I get a screwy result and I repeat it, then I will usually add one of those 2 measures to make sure that the test was done correctly. And this is the best test for looking for cortisol production from an incidentally discovered adrenal mass. I'll talk about that at the end. So you do get false positives again in the pseudo-Cushing state. You can get false positives from people taking estrogens because it increases corticosteroid binding globulin, and even though their free cortisol will suppress, their total cortisol will not totally suppress because of that binding protein. Renal insufficiency, we were talking about this, is another false positive because people don't clear the cortisol as well. Rapid dexamethasone metabolism, so drugs that induce 3A4 such as rifampin, and then false negatives from 3A4 inhibitors. So what cutoff do we use? So this is a bunch of people with proven pituitary Cushing's, okay? And here's their dex expression test. So most of them are over 10, and then a smattering of them are between 2 and 10. And even a couple of people are less than 2. So for ACTH-dependent disease, it's not a great test, but for ACTH-independent disease, it is. All right, and then the last approach takes advantage of the diurnal rhythm. So, when you were asleep last night, unless you were on call and getting waken up or worried about coronavirus, between midnight and about 3 a.m., your cortisol level, my cortisol levels were pretty low. And then, when you get up in the morning, one of the reasons you wake up is because your axis kicks into gear and you start to make cortisol about 6 a.m. or 4 a.m. And then it peaks in the morning, and then it comes down in the afternoon, and then it drifts down later in the day. So, general principle of endocrinology, if you think it's high, you measure it when it should be low. If you think it's low, you try to stimulate it, and so on. So, we're thinking that cortisol production is high. So if it's high, then this nadir in the early morning hours won't happen. So nocturnal testing, you can measure cortisol. We used to do this. We used to bring people in the hospital, put a hep block in, and measure cortisol samples through the night. And if their serum cortisol fails to fall below 7.5, that would be diagnostic of Cushing syndrome. And then anything less than 5 would rule it out. So there was still a gray zone there. But now we do outpatient saliva cortisol, and it has the added advantage that saliva is an ultrafiltrate of plasma. So it actually corrects for CBG problems. So for example, it's not a problem if someone's taking estrogen or if they have liver disease or things like that. So normally we get 2 or 3 on consecutive days during a week period between 11 p.m. and midnight. And if it's less than 100 nanograms per deciliter, that's normal. And greater than 250 nanograms per deciliter is consistent with Cushing syndrome. There are also a few problems. If people have bleeding gums, then they get some blood in the sample, and that has a much higher cortisol than the saliva. So some labs actually test for blood. They do a little hemoglobin test on that. So people aren't supposed to brush their teeth or drink hot liquids for an hour before they do the test. So how good is this test? It's pretty good. So here's normal people with Cushing syndrome, and people who were referred to rule out Cushing syndrome. Not 100% discriminatory, but pretty darn good. And so this is what we do usually to test for ACTH-dependent disease. So just to kind of bring this all together for the first part, for just telling if someone has hypercortisolism or not. First, there's non-neoplastic disease, so psychiatric diseases, critical illness, and others. If they have any of those, don't test them. If they don't, then you do the biochemical testing, one of these 3 approaches. If it's negative, you stop. If it's positive, then they have endogenous hypercortisolism. And then we have to ask, is it ACTH-dependent or not? So we measure an ACTH in the morning. And if it's not, we're thinking about adrenal tumors. We do an adrenal CT scan. If it is, then it can either be pituitary Cushing syndrome or Cushing's disease, which would be the most common. It could be the ectopic Cushing syndrome, or it could be the ectopic CRH syndrome, which is extremely rare. And so to sort that out, we do a pituitary MRI, a SELA MRI, and then something called inferior petrosal sinus sampling. I'll talk about that in a second, and then other imaging. So we have to now sort of do the where's Waldo, where is the ACTH coming from? The problem with, you would say, well, we'll just do an MRI, and if there's a tumor there, you know that it's there. But the problem is the SELA MRI is as likely to be abnormal in pituitary Cushing syndrome as the ectopic ACTH syndrome. Why is that? Because 10% of us have some abnormality in our pituitary that you will pick up on an MRI, and we don't have Cushing's, okay? So if you just think about that, and you think of how rare Cushing's disease is, 1 in 10,000, most of the abnormalities you're going to find on an MRI are not going to be due to the Cushing's, okay, or about half of them are. And then many Cushing's tumors are very small, less than 4 millimeters, and so sometimes you don't see those on the MRI. So if we see a convincing tumor with the right imaging characteristics at least about 6 millimeters, then we're comfortable with that. But most of the time, we wind up sending people to what's called inferior petrosal sinus sampling. So the petrosal sinuses are the venous drainage of the pituitary. And the radiologist will thread catheters up into that area, and they'll measure the ACTH levels in the blood dripping out of the pituitary. And they'll tell if it's higher there, if it's coming from the pituitary, it'll be higher there than it is in the inferior vena cava. And so they'll shoot some dye in on this side, and it should reflux over to the other side. But remember, you don't do this to diagnose Cushing syndrome. Okay, you don't do this to diagnose cortisol excess. Do the biochemical testing and the physical exam to diagnose cortisol excess. Because if I do petrosal sinus sampling on you or I, it will be coming from the pituitary. Okay, that doesn't mean I have a pituitary tumor. That means I have a normal pituitary axis. Okay. So it only excludes the ectopic ACTH syndrome. And to show you some data, if you look at the gradient from the petrosal sinus to the periphery in people with Cushing's disease, and this is before or after giving a bolus of CRH to stimulate the tumor, most people have a gradient of at least 2, whereas the people with ectopic ACTH syndrome have no gradient. And then after CRH, then pretty much everybody is over 2 and nobody with the ectopic syndrome. So how does this work? Let me just give you an example. This is a 33-year-old woman that was referred for us for oligomenorrhea, and her hirsutism, she's thin, but she has facial plethora, and she has dorsal cervical and supraclavicular fullness and easy bruising. So her urinary free cortisol is 500, so it's 25 times normal. And her late night saliva cortisol is elevated, and her ACTH is 65. And she has an MRI that's not totally normal, so she has some stalk deviation. She may have what looks like an adenoma on the right side there. But it wasn't convincing, so we took her to petrosal sinus sampling. And so we measure ACTH and prolactin in the sample. So we know the prolactin's got to be coming from the pituitary. So that tells us that the right and the left sides, that we got a good sample on the right side because the prolactin is higher than the peripheral vein. But we did not get a good sample on the left side, so I'm going to discount that. But when I look at the right side, the ACTHs are no higher than they are in the peripheral vein. So she does not have pituitary Cushing's. So what does she have? So we've been doing gallium dotatate scans, which is a somatostatin imaging agent. And so the normal pituitary lights up, the thyroid lights up because of the C cells of the thyroid, but she also has something over here in her chest, which when you register with the CT is over there, and she has actually a neuroendocrine tumor of her lung that is making ACTH and causing her Cushing. And if we didn't do petrosal sinus sampling, we would have operated on her pituitary for no reason. So then she went to the chest surgeon, had this taken out, and is in remission now. All right, so that's ACTH-dependent disease. So what about ACTH-independent disease? It comes in 4 flavors. You can have adrenal cancer, and we see a lot of adrenal cancer at the University of Michigan. About a third of the patients in the country with adrenal cancer come to see us at one point. You can have macronodular hyperplasia, which is a goiter of the adrenal gland. It's big, lumpy adrenals on both sides. You can have micronodular hyperplasia. These adrenals look pretty normal, but this person has florid Cushing's and a suppressed ACTH. Highly functional cyclic AMP dependent cortisol production. And then, this is the macronodular hyperplasia. We have nodules on both sides, and then in adenoma would be a single adenoma that's causing hypercortisolism. And of these, this is extremely rare. This is quite rare too. This is not extremely rare, but it's less common, and this is the most common, the adenoma. And people with adrenal adenomas often have mild Cushing syndrome. And so I want to spend the next section talking about this. So if you thought overt Cushing's was hard, okay, now let's push the envelope back and try to diagnose it earlier, okay? And these people usually lack those specific findings that I told you to look for on exam, but not always. And the less specific findings, like obesity, are common. Hypertension is common. The labs overlap with normal. And most of these people have incidentally discovered adrenal nodules. Now, and the literature, most commonly they call it subclinical Cushing syndrome. I don't like that term because I do not believe this is a subclinical disease. I believe this is a relevant disease. We use the term non-classic Cushing syndrome, similar to non-classic congenital adrenal hyperplasia. I make no apology for talking about subclinical or early disease because almost everything we do in 2020 is early disease. Asymptomatic hyperparathyroidism, thyroid nodules, osteopenia, subclinical hyperthyroidism and hypothyroidism. This is what we see. So why should we not see subclinical Cushing's? And maybe a couple of years I'll come back and talk about subclinical primary aldosteronism. That would blow your mind. And there's plenty of evidence now that this is not a benign disease. So how do we test for this? Well, if you have a thyroid nodule, you measure a TSH, right? Because the pituitary thyroid axis will tell you if the thermostat is sensing too much heat. Okay, now with the adrenal axis, it's not quite so simple because of this circadian rhythm, because of the response to stress, just doing a blood draw. But there's a couple ways that we can cite this out. And what are the consequences of this? Well, up to 90% of these people have hypertension. So this is sort of, when people say how common is secondary hypertension, Well, we don't really know because we don't do CT scans on everybody with hypertension. We certainly don't measure aldosterone and renin in everybody with hypertension. We do a dexamethasone suppression test. About a third of them have impaired glucose tolerance. There's a higher prevalence of hypertriglyceridemia. There's unfavorable cardiovascular risk factor, unexplained osteoporosis. But one thing that I will tell you is that it's more common when the tumor is over about 2.5 centimeters. So the good news is that most people with 0.5 centimeter, 1 centimeter nodules, you don't need to obsess over. But when the tumors get larger, like the one I showed you on the previous slide, they get over about an inch long, then the prevalence of hypercortisolism becomes significant. And how do we test them? So when you have an incidental adrenal nodule, we recommend that you do an overnight dexamethasone suppression test. 1 milligram, yes, you can do 2 or 3 milligrams if you want. It doesn't matter because really what you're asking is when I lower the ACTH to 0, how much cortisol is still coming out? So unlike pituitary Cushing's, where you're doing an empiric difference between the feedback mechanism for the normal pituitary and the pituitary adenoma, here you're asking a specific question, which is how much cortisol does this patient make in the absence of ACTH? Because these people usually have low ACTH, but not 0 ACTH. So again, we do a plasma ACTH. It has to be done early in the morning in a low stress environment. And then another thing that's very useful, particularly in patients who are less than 65 years old, is a serum DHEA sulfate, because it is also ACTH dependent, just like cortisol, but it does not have much of a diurnal rhythm. And it's secreted in larger amounts and circulates at higher levels than pretty much any other steroid in the body. And so when your ACTH is chronically low, your DHEAS will tend to drift down. And if you have a clear diagnosis, you're done. If you don't, we usually repeat it at least once, 6 to 12 weeks later, and then we decide if we're going to dismiss these people for routine follow-up or if we're going to see them and measure them periodically. So here's the schematic. This is the normal hypothalamic pituitary adrenal axis. ACTH is driving both DHEAS and cortisol production. Only cortisol provides the negative feedback. So now if I have a tumor that's making a little bit of cortisol, it's going to lower ACTH chronically. So not only the ACTH is going to be low, but the DHEAS is going to be low, okay? And that's how we use that. And I'll show you an example of this in a second. So I told you there are consequences to this, and I think there are 3 studies that have looked at, for example, what is the prevalence of Cushing syndrome in patients with poorly controlled type 2 diabetes, all right? And you may say, well, it's rare, it's 1 in 10,000, but it's not rare in this population. So these 3 studies have found it's about 3%. About 3% of people have undiagnosed Cushing's. And I'm going to show you the last study, the Katorgi study. It took 200 obese diabetics who had an A1C of greater than 8%, and they started with an overnight dex suppression test. They had a very low cutoff, and 52 out of the 200 failed that first cutoff. And then they had further testing, and they determined that 30 of them were normal, but 17 of them were still abnormal. Now, they did imaging on them and ACTH measurement, and they found that 3 of those people had bona fide pituitary Cushing's disease. 3 of them were normal, but 8 of them had adrenal tumors, okay? This is not a coincidence, okay? This is what wakes me up in the middle of the night in a cold sweat, thinking about how many people with adrenal Cushing's that we are missing in our diabetes clinic, okay? And this is about 4% of those people, okay? And I'll show you an example here. So this is a young woman, 37 years old, who's recently developed hypertension and impaired fasting glucose, and she came into the emergency room with abdominal pain one day and got a CT scan, and she had a 2.3 centimeter left adrenal mass. Yes, she's had some mild weight gain, but her menses are regular. And on physical exam, she has some subtle findings of the beginnings of Cushing syndrome. So we tested her once, twice, 3 times, and so her ACTH was a little low, her DHEAS was normal, and her overnight dex suppression test was normal, but not 0. So we repeated the testing in 6 months. Now her ACTH is down to 8. Her overnight dex suppression test is over 2, and her DHEAS has fallen to 71. And then 5 months later, now her ACTH is pretty much undetectable. Her DHEAS is all the way down to 41. Her overnight dex suppression test is 2.1. And her tumor has grown from 2.3 centimeters to 2.9 centimeters. This is Cushing's, okay? And yes, she needs surgery for this. And what can you tell her is going to get better with the surgery? Well, when I was in Dallas, we started taking care of people like this and offering them surgery. And so what we found, like most of these people, like I said, only one of them had an elevated urinary free cortisol, but they had abnormal DECT suppression tests, low ACTH, low DHEAS. And I think one of the important things is that after surgery, not only did their ACTH go up, but we took out one adrenal gland and their DHEAS went up, okay? That's because the ACTH has been suppressed, okay? And so that's one of the signs that you have. And so the improvements were much better than we predicted. We didn't promise them this, but we found that 100% of them, the bruising, the plethora got better. The weight gain improved in almost everybody. 75%, the hypertension got better. Diabetes in 2/3. So this was a significant improvement from something that at that time was not the standard of care. Now, this result has been replicated in several series, particularly this Italian series, where they took several patients with subclinical hypercortisolism, as they call it, and they either randomized them to surgery or not surgery. And I'm just going to summarize here. If you look at their blood pressure, it went down in the people that had surgery. It did not go down. If anything, it went up in the people who had surgery. If you look at glucose, it went down in the people that didn't, and went up in the people who didn't have surgery. So over time, this is not going to get better. And over time, this is going to cause problems for people. There's increased mortality from this mild hypercortisolism. And so we often tell people, well, we may not fix anything you have. You may look okay today, but 20 years from now, you're going to have trouble. And so we've been a little more aggressive about this in recent years. So I want to finish talking a little bit about medical management of hypercortisolism. Surgery is the treatment for hypercortisolism of any sort. And we have great endocrine surgeons and pituitary surgeons and chest surgeons that we work with on these. But sometimes you can't do surgery, or sometimes surgery fails. So what are your options? So cabergoline, which is a dopamine agonist that we use to treat hyperprolactinemia, sometimes works in Cushing's disease, in pituitary Cushing's disease. And then pasireotide has now been FDA approved for the treatment of Cushing's disease. It's a somatostatin analog that has high affinity for the SST5 subtype of somatostatin receptors, which is the one that Cushing's tumors tend to express. Mifepristone is now also FDA approved. It's a glucocorticoid receptor antagonist, but it's also a progesterone antagonist, so it has to be used with caution in that case. Ketoconazole, and now levoketoconazole is in trials. It inhibits multiple enzymes of steroidogenesis. The ketoconazole is an off-label use. It has black box warning. I'll review the data briefly on that. But if the problem is that to get people with bad Cushing's to normal, you usually have to use pretty high doses, and people run into problems with side effects. The latest is osilodrostat, which we used to call LCI 699. Between the time when I sent these slides in and today, this drug has been FDA approved for the treatment of pituitary Cushing's disease. We were the top enroller in the United States for that trial, and we have some experience with this very potent drug. It's an 11-hydroxylase inhibitor. The other 11-hydroxylase deficiency inhibitor that's an old drug is metirapone. Metirapone is very useful, particularly in the acute setting, but it has to be given 4 times a day, 3 or 4 times a day, whereas osilodrostat is once or twice a day, and the dose is about 1,000 times less, so it's much, much more potent. And etomidate, for people in the intensive care unit, is actually a really good drug for Cushing's. It is an 11-hydroxylase inhibitor, and during the Endocrine Society 2 years ago, we had 3 people in the University of Michigan Hospital on etomidate drips with Cushing's of various sorts. And Jay Finling has published a protocol for that. So I want to first mention peri and postoperative cortisol management. So in the hospital, what we do is we try not to give them any glucocorticoid, and we measure serial ACTHs and cortisols. And if their cortisol is less than 3 on 2 occasions, we start treatment. If not, then we know they're not cured. So, like our pituitary patients, they're like in the neuro ICU, like what's going to happen if we don't give them glucocorticoids? So it is safe to not give them glucocorticoids under monitoring for a day or two. And then we sort of try to taper the hydrocortisone and shift them to morning only as their axis recovered. I will say that this is one of the hardest things for patients with Cushing's. I always tell them that I have good news and bad news. The good news is we know what you got, we're going to fix you. The bad news is you're going to feel worse before you feel better. They will have what we call the cortisol withdrawal syndrome. And they have muscle aches. They feel like they have the flu constantly. They don't want to eat, but that's their body trying to get back to normal. And I think this is something that we still need to study. We give them NSAIDs, particularly celecoxib for the muscle aches, SSRIs for symptom control, and so on. And then we just measure their morning cortisol, ACTH, DHEA sulfate before their morning dose of cortisol. And my rule of thumb is the hydrocortisone dose plus the AM cortisol equals 20. So, when they get a little blip and we can finally measure cortisol of 0.3, then we drop them to 20 milligrams a day. And then when they come up to 5, we drop them to 15 milligrams a day. When they get to 10, we drop them to 10 milligrams a day, and eventually they come off. And then venous, we were talking about venous thromboembolism prophylaxis. Now we send people home on a month of low molecular weight heparin. It is a big deal. I'm going to go through briefly a couple of the new drugs. This is pasireotide. That was given as a sub-Q injection twice a day. And, these are sort of waterfall plots. The urinary free cortisol goes down in the majority of patients, not everybody, but it doesn't come to normal in the majority. So about 90% of people respond, but only about a quarter of them get to normal. Now, mifepristone, which is an antagonist, does not lower cortisol. So you can't measure cortisol as an endpoint. But what we measured in the people who had abnormal glucose tolerance was the area under the curve for the glucose tolerance test. And within 6 weeks, there was a dramatic improvement. So when we start people on this drug, if they're on insulin or whatever, we have to cut their meds, except for metformin, in half before we start it. And you really have to go slowly because they will get the cortisol withdrawal syndrome from this drug. So the good news is that they get rapid and sustained improvement in glycemic control, clinically significant improvement, 7% weight loss over 6 months, and a weight loss around the midsection. The women dropped 3 dress sizes during 6 months. And it's oral and it's once a day. But if they have hypokalemia, you have to deal with that separately because it does not block the mineralocorticoid receptor, which cortisol also will agonize. You can't use serum cortisol to monitor, and because it's also a progesterone antagonist, the women can get endometrial hypertrophy. It is a 3A4 metabolized drug, although the drug-drug interactions are not as bad as we initially worried, and it's very expensive. This is just a little bit about ketoconazole. This is a retrospective review of patients. And the problem is that, when it's less than 400 milligrams a day, that's the usual dose of ketoconazole. Not many people are controlled, so usually you have to use higher doses, and only about half of people stay on. About a quarter of them stop because of lack of efficacy, and about a quarter of them stop because of side effects. Now, levoketoconazole, which is one of the 2 enantiomers of ketoconazole, we just finished this trial that we participated in called the Sonics trial, and the waterfall plots are pretty good. People are getting close to the limits of urinary free cortisol, but still some people had elevated LFTs on this drug. Now, osilodrostat, I mentioned, the new miptirapone, given 2 to 50 milligrams twice a day. There was a phase 2 study, and 11 of 11 patients normalized their urinary free cortisol. There were 2 phase 3 studies that one is completed, one is almost done. The link 3 was randomized withdrawal in the middle. Link 4 was randomized up front. So the link 3 results, again, here's the waterfall plots, nice lowering of urinary free cortisol in almost everybody. And so about 66% of patients maintain normal urinary free cortisol for at least 6 months after normalization. And then during the randomized withdrawal phase, 86% of people maintained normal urinary free cortisol who were on drug. Now, about 30% of the people who were withdrawn maintained a normal urinary free cortisol, which is why we say you have to do the experiment and you have to do it right. But still, this was, it wasn't 100% versus 0, but it was still tremendously statistically significant. So to finish, the unsolved problems in Cushing syndrome is really getting a definition of this non-classic Cushing syndrome and trying to figure out who benefits significantly from treatment to justify treatment, particularly if we can't do surgery, if we have to do medical therapy with the limited repertoire that we have, who are the candidates for that? How do we deal with the glucocorticoid withdrawal syndrome? Why do they get such bad thromboembolism, and how do we prevent it? And what are the best medical therapies in the sequencing? And the last thing is that part of the bad news is that people who have had bad Cushing's, they often never get back to normal, particularly their cognitive function. Susan Webb has studied this, and people have long-term morbidities from this when they're not diagnosed soon enough. So it is imperative that these people are picked up before they get hippocampal atrophy and other CNS complications that are just not going to get better no matter what we do. So one of the reasons that we're endocrinologists is because this woman who I took care of in Dallas, who had to stop working, she couldn't take care of her kids. She was on 5 or 6 drugs for her blood pressure, and her diabetes is now looking like she used to look, because we were able to cure her Cushing's and get her off all her medicines and taking care of her family and living her life like she wanted to. So with that, I want to again thank you all for this great honor and invitation. I want to give my respect for Dr. Towery, and I thank you for your attention.
So if anyone has any questions for Dr. Auchus, this would be a lovely time to ask them.
What is the frequency with which you test the people with non-classic have an adrenal nodule?
Well, so people who have an adrenal adenoma, we test everybody once. It's really a matter of, do we test them repeatedly? And again, I think depending on what their clinical picture is, how large the tumor is, and what the results of the first test are, determine whether we follow them or dismiss them. So 1 centimeter tumor, no clinical features, totally normal test result, we would just say, go back to your primary care doctor. If you develop sudden change in your blood sugar, hypertension, we should readdress this, but we're not going to test you routinely. And unfortunately, we have to re-image these people once. The smaller tumors, we usually wait a year. But if someone comes in with a 3 centimeter tumor, I'm not only going to do a DEX suppression test, but I'm also going to measure an ACTH and a DHAS, because my index of suspicion is much higher that up front they're going to be abnormal. But usually we just start with the DEX suppression test and see if that's abnormal, and only do additional testing if that's either abnormal or equivocal. The elephant in the room is how many people with poorly controlled diabetes that you don't know whether they have an adrenal nodule do you test. And again, I think that my guidance on that is that if they have some of the more specific features. So again, oftentimes people, if you follow them with time, they will develop the supraclavicular fat pads. They will get easy bruising and skin thinning, things like that you can't fake. But smokers have thin skin, and there's a few other issues. People are on apixaban or whatever for heart disease. So I think you have to have some reason for doing it. Or if people just aren't, they're relatively thin and they're not responding to the usual diabetes therapies. But that's, I think, the real elephant in the room.
So early on, you said you would dismiss people with psychiatric diseases as having pseudocushing. So because
yes,
you get psychosis and depression as so common manifestations of Cushing, you want to clarify?
Yeah, so that's actually an excellent point. So I don't want to be dismissive of that. So we have, in people, particularly with the ectopic ACTH syndrome, can come in with psychosis or mental slowing and stuff, that 1 or 2 doses of metilprednisolone or mifepristone and they wake up and can start thinking clearly. So yes, Cushing's does cause depression, and the depression caused by Cushing's does not respond very well to the usual antidepressants. So depression in itself is a manifestation of Cushing. But what I was saying, in an acute psychiatric, like acute delirium or in an acute manic episode is not a good time to test. Wait until the patient has been stabilized and then test them. So as opposed to chronic depression, when it's okay to test them because it could be a symptom of Cushing. So acute versus chronic. Yeah.
I'm going to ask a question that's probably going to drive you nuts. Instead of Cushing's disease on the opposite end of it, you can go in any health food store and it's adrenal fatigue. Let's take all this licorice. Let's do this and this. And my question is kind of how often can that or could that actually alter the test or confound things? People send these home saliva kits away and come to the doctor and tell them what they have, and they can be useful, they can be confusing.
Yeah, so some of these things actually have adrenal extracts in it, and so they are glucocorticoids, and they can suppress, but temporarily because they're given orally. So those people, they'll have a low ACTH and a low cortisol. We try to debunk these myths. You go to one website and it says, "Are you fat and tired?" Well, you have Cushing's. Or and the other website says, "Well, are you fat or tired?" You have adrenal insufficiency. Yeah. So they can't both be right. It's like the polar opposites. So again, these people that are seeing non-endocrinologists that are getting misled by these scams. It's best to sort of step back and ask for the big picture. And usually it's a sleep disorder. I mean, most of the people that are coming in with these problems that the doctor says there's nothing wrong with me, they're just not, they either have sleep apnea or they're just not sleeping well. And, so usually what I say is, when you wake up in the morning, do you feel good or do you feel tired? And if you feel good, do you get tired as the day goes on? If you wake up feeling good and then you get tired as the day goes on, it might be a hormonal problem. If you wake up not feeling good, it's probably a sleep problem. So that's, I think, the critical question. And then I try to emphasize them, you don't want to have Cushing's and you do not want to have adrenal insufficiency because people die from both of those things. You can't get life insurance if you have adrenal insufficiency. You can't serve in the military, fire department. There's a lot of things, it is a bad thing to have. So I try to kind of put them in the big picture and try to emphasize I'm trying to help them, but this is not going to help them. And we need to really get down to what is really going on. It would be great if every adult in the United States could have a sleep study once a year. Yeah.
So one of the things that happens when you come to Louisville is you may have heard that we have something called the Louisville Slugger.
Oh, yes.
When we invite you to come to speak for our grand rounds, we send you home with a lot of luggage, including
some wood.
A Louisville Slugger.
Oh, my goodness.
This one is engraved with Richard J. Auchus, MD, 2020 Beverly Towery Lecture, University of Louisville, March 12, the first full day of the coronavirus pandemic.
Right.
So this is lovely for you to have.
And ready right in time for the baseball season if it gets off the ground. I have actually a couple of these. When I was a kid, we used to go to bat day at Yankee Stadium. So I have a Mickey Mantle one, and so I have a couple of these. But this one I will treasure. So thank you very much.